Hello, I'm Richard Meyrick. This is the second of my diary blogs, which will record my treatment for carpometacarpal joint problems. That is the base of my thumb in both hands. The joint there is absolutely finished, and I'm making these videos for the sake of other dedicated keyboard players and pianists who may sadly share this pretty severe problem. It's severe arthritis. My joints are totally wrecked after 55 years of playing the piano, many of those for 6 to 8 hours a day and playing internationally. So I've been elected to have trapeziectomies, with a difference in that I'm having an insert put into my actual metacarpal. And so that will act as a spacer between that and the scaphoid, which is apparently a superior way of doing it and quite a new way of doing a trapeziectomy for this sort of purpose. Yesterday I arrived at the hospital as instructed at 12:30. There's always a surprise when you get to a hospital for an operation. They always bring something on you, and you may, if you've seen my first blog, have made note of the fact that I would love to have watched this operation. I didn't think they'd let me, and they certainly didn't. I thought I was going to just have local anaesthetic, and they said, no, you've got to have general anaesthesia. The reason being, this very, very kind and very nice young lady anaesthetist was telling me is that she'd have to inject into my neck to find the nerve to paralyze my arm, to send that to sleep, and it could potentially cause problems. They don't always get it 100% right. Sometimes they have to top up with further injections in your arm, and it can cause a small percentage of nerve damage, which to a non-pianist they would hardly notice, but to a pianist they probably would. So she said it all stacks up and you should have a general anaesthetic, and the surgeons think so. My response to that was that hospitals do not discharge you until you've been able to pass a little urine, which has always been my problem after a general anaesthetic. I related this to my anaesthetist, and she said, don't worry about it, we'll cross that one when we come to it. And I was reminded of listening to a radio program, probably Desert Island Discs, in which there was this very erudite professor who'd had a very active and very accomplished life. And he said that in his late 60s, he'd had this major surgery, and recovering from it, his whole being, all of his life's history seemed to be condensed into that one toilet scene when he was standing there for hours just trying to pass this first drop of liquid, and he couldn't do it. Last night, well, mine only lasted 25 minutes of absolutely intense concentration, and finally that little drop appeared, and glory, hallelujah. We're going home, I shouted, and off we went, and managed to sleep in my own bed last night and managed to get the car home safely with my wife driving. It all got home in one piece, so all was well. My two surgeons were absolutely tremendous. I said to them when they first came in the room before the operation, can I ask you some serious technical questions? Now, 30, 40 years ago, that would have been anathema for a consultant to even consider such a thing. And they said, yeah, go ahead, what do you want to know? And I said, well, in your book, one of them had written a book on hand surgery for musicians. He's an international surgeon. I said, you always choose the smallest size, it says, of implant when there's a choice of 5 or more. He said, I always do. And I said, but isn't that going to affect my span on the piano, which normally is about 1/10? Isn't it going to bring it down from that? He said, not at all. I said, fine. I said, if you find any osteophytes, there's little protrusions of bone from the arthritis. He said, we'll take care of all that. They're all going. Good. I said, what if the arthritis affects the bone next to the trapezium, the trapezioid? He said, I can't remember what he said, but what he did say satisfied me. My main worry was what they were going to do with the tendon, which they were going to make the sling with, and whether they were going to sever it or splice it. He said, oh, we're not going to sever it. We're going to splice it and we're going to use that, which was a great relief to me because I've still got half my tendon, which is quite important, I think. I asked him how he's going to make the canal in the metacarpal and so on, but they were only too happy to answer all those questions. The operation was apparently extremely successful. There it is. I had a new knee 3 or 4 years ago. This isn't in the same category as that. A knee was pretty painful. This is painful. It's always harder to get out of pain once you're in it than it is. So it is much, much better to avoid excessive pain in the first place. In other words, I've always been told by the medical people that there's no prize for not taking painkillers. Take them, even if the pain isn't terrible. And it wasn't terrible last night until I got home when the some of the local they put in during the course of the operation started to wear off. And after that it did get bad. I took pretty heavy doses of codeine paracetamol. That's 30 milligrams of codeine, 500 paracetamol, and I took that twice in the evening through the night. And had to keep my arm up, so I banked up my bed with pillows either side so I could keep my arm. It's got to be elevated for at least 24 hours is what I'm told, in order to keep the swelling down. I was told it would swell up. So far it hasn't swelled up. They're brown because they've got betamethasone or whatever they put on it. I don't know. It's the antiseptic. But so far so good. I've got to keep it like this for 2 weeks and then go back, see the therapist, have the stitches inside there removed. This is pretty solid, but quite honestly it's not as bad as I thought it was going to be. It really isn't. Maybe I'm speaking too soon. I've got to get through today. I'll probably sleep quite a lot today, but I will keep you informed. That's all for now. That's all I've got to say. Thanks for watching.